Hi, I'm Dr. Neel Shah, and welcome to the DBT Podcast. Welcome to the DBT Podcast. My name is Dr. Neel Shah. I'm a hematologist oncologist, and very lucky to be joined here by my friend. I've known him for over 10 years, Dr. Joe Legaspi. How you doing today, Joe?
Pretty good, Neil. Glad to be here.
Yeah, thanks a lot. Thanks a lot. I know you've been practicing medicine for so many years, and as an internal medicine doctor that takes care of adults, I think everyone sees their general doctor, and we really today I think I wanted to talk to you about obesity and men's health in particular. I know those are some chronic medical problems that you see, and I know you take care of a large number of patients dealing with some of those issues. And so let's say, a new patient walks into your office, and how do you define, like, when do you tell someone, you meet with them for the first time, is there a specific weight based on their height that you're saying, okay, you know what, you need to lose a little weight, and here are the ways you do that. And, we all here now, everyone that's listening to this podcast knows about all these new drugs, right? Ozempic, Wegovy, and they're very good at advertising. But I kind of want to know, from a general aspect, what you do when you see these patients. Someone walks in first time, and like what advice you're giving.
So the first part that I see is that, part of the vital signs is their weight. So obviously the BMI is their kilogram over their height, which is in meters squared. So if they break the plane between 28 to 30, that's overweight. Past 30 is obesity. So there's between mild, moderate, and morbid obesity. So the risk factors like high blood pressure, diabetes comes up. So the level of how aggressive we treat depends on the risk factors. And again, weight loss is driven by a healthy diet and exercise. But again, the new meds like GLPs have come to the forefront to help a lot of patients.
Yeah, I mean, you guys are on the forefront of prescribing those things. Obviously, I don't really prescribe it, but, in general, I think of obesity, and I want you to correct me if I'm wrong, as just chronic inflammatory state that, leads to, cancer. It's the number one risk factor, but also, the number one cause of death is heart disease. So, I think, I know you're really good at talking to your patients about these types of things. And, I don't know if there's a specific plan that you kind of, or do you tailor it to every patient, or is there a specific plan? You're like, hey, you know what? You're 200 pounds. Let's try to get you down. I'm going to see you in 3 months. Here's a plan for you to try to get your weight down before we go to those, trying to use drugs.
Yes, I'm a big fan of like formulating like a diet. For example, we do small frequent feedings. So, if you're eating every couple hours, you're not going to take down a 5 course meal for lunch and dinner. And then as far as exercise, something easy, 30 minutes of walking 4 times a week. And again, if they fail to make any progress within like a couple of months, obviously uh, meds will be in question. And again, one of those meds may be a GLP-1, especially if we're looking at a good amount of weight loss is needed.
Yeah, I mean, I'm thinking that the Bears won't make any progress this year after 3 months. I don't know. I've had a lot of friends recently that listened to the podcast last couple episodes, and a lot of them want to place bets with me. And I talked to this about even some patients. That the Bears are going to win more games than the Lions. I'm not talking about winning the division. I'm not talking about the Super Bowl. I'm talking specifically about wins. Are you willing to take that risk? And you and I can just place a bet right here on whether the
Okay.
Bears win more games than the Lions.
I think I'm willing to put some money to that. I'd have to. You and I have gone to some Lions and Bears games, Neil, and then before they got good, it was also given the Bears would win that game, but that's no longer a proposition.
Yeah, so maybe we can do something like this. We can go ahead and make you watch a Lions game without the Bears in it. That'll be the bet. Maybe something of that nature. But yeah, I don't know. I know you got our coaches, but player for player, I still think we have more talent. And I don't know. I heard Kelly Williams has been throwing a lot of interceptions in practice. I don't know if he. Maybe there's something maybe he should see a doctor. I mean, I don't know. Is there a cure for interceptions that you could give him?
Last time I checked, even Ozempic can't fix that.
Yeah, I know. So, I mean, these athletes, these fine-tuned athletes, we will think of them as, the strongest, healthiest people alive to do these feats, right? They're getting
Right.
hit or they're throwing or they're doing these things. But, you know, many times, you have a famous quarterback, very well liked in Chicago, Jay Cutler, who had diabetes and he didn't know it. He kept losing weight and they figured that out. So, I'm just wondering, like, human beings, like a lot of times, people think that you can't get diseases if you're an athlete or you're completely healthy. But I think, it's another example of people, someone that, had a disease that required some medical treatment because the human body malfunctioned, I guess, in a certain sort of way.
Yes.
And do you specifically test when you see, let's say, men over 50? Are you, or men in general, are you testing them, for all these things like diabetes and thyroid problems and all these
I
types of
am.
things?
Yeah, and the big piece that I have is, for example, if they have a family history of diabetes or high blood pressure, I'm very on point about trying to reach the goals. Part of what drives low testosterone is both obesity and thyroid disease. So, if a patient over 50 receives the appropriate amount of testosterone, his ability for stamina, mental health, walking, and basically overall health will be a benefit. And again, one of the things for obesity that has been mentioned is the GLP-1s. Um, Disease like sleep apnea come with obesity, so there's an actual indication for GLP-1s to treat sleep apnea. So yes, I see patients over 50 benefiting from weight loss, and again, amongst other that is we're seeing low T as a more common as we look for more for it.
I mean, I think we learn more and more about testosterone. I'd say, you've been doing this, what, 25 years now, is it?
Almost, yes, yes,
I guess I'd ask you in your own practice, like from 25 years ago, we now have drugs, better drugs for the most common diseases, right? Like diabetes, even blood pressure, cholesterol. Now we have drugs for weight loss. You know,
yes,
I think, more and more we're able to find these chronic diseases and treat them. What do you think the
right.
biggest difference is the last 25 years in terms of, like we're also seeing more disease. Why are people, getting all these, more and more diseases, including cancer? What do you think is driving it? Do you think it's just obesity? I mean, smoking's actually gone down. Education has actually gone up. So is it just obesity? Do you think that's driving it, or is there other factors, do you think?
I think between obesity and stress, those are very strong factors that drives blood pressure issues, diabetes, and low testosterone. So again, if you look at, I know you and I have traveled in Europe. You see that Italian man makes 30,000, lives in Amalfi Coast, eats like cheese and wine. They are very happy and wear size 28 pants.
I mean, the stress factor is definitely one. I know that Bears fans are stressed about, becoming good this year, but in general, our day-to-day stress, is there, a way, like, is there anything you're recommending in terms of stress reduction? Is it, going on trips? Is it drinking more wine? Is it, well, is there something about like saying every day waking up or thinking about stress and meditation, prayer, are those part of your practice to kind of recommend those types of things?
I am actually one of the biggest factors that I've seen with a patient having with weight loss is exercise. I'll share a story. I had a patient who was basically in a morbidly obese state, had family history of diabetes. He qualified for GLP-1 and obviously slowly started getting the weight off. Low testosterone was treated. And the last thing I know, he qualified for the Berlin Marathon.
That's amazing. For someone to, be kind of out of it and recover, the human body is kind of an amazing thing that, we're able to, to do that. So, um, what point do you think someone actually needs testosterone? Is it just the lab value? Like a male needs testosterone. Is it just the lab value, or do they need to be symptomatic? Like, let's say you have low testosterone. I think there's other ways to raise it besides taking testosterone, shots or supplements or whatever. Is there other things someone could do to raise their testosterone, like exercise or weight loss? Will that in itself help with testosterone, or is it just that we're getting older and our testosterone is going to decline, and there's nothing else we can do besides just take it?
So that's a great question. Testosterone concentration is offended. It's basically affected by the sex binding hormone globulin, which is depleted when somebody is obese or not treated for the thyroid. So if you think about it, if you treat the obesity, treat the thyroid, you are literally boosting your concentration of free testosterone in your body. So yes, you are correct. That means you're doing outside of testosterone replacement. You can treat that.
All right. So what are the things that are you, if someone has a little low testosterone but they feel great, are you testing it on everybody? Like, what age do you just test everyone for testosterone?
So testosterone is being checked. If you look at uh, the metabolic syndrome, which is basically obesity, thicker neck, uh, impaired fasting glucose, and family history. And then a lot of this, they are usually high cholesterol. And then, of course, their BMI, they're breaking 28, 29, 30.
Yeah. So if someone's fatigued, then you're checking testosterone. Is that what you're doing for everybody then, basically?
Yes, yes, I am.
And like, fatigue is such a subjective symptom, right? I mean, I get,
Correct.
get asked that all the time. I myself
Yes.
get fatigued when, I see the Lions not doing well. I can start getting a little tired. But
Yes.
so, I find that like one focus that, I'm talking more and more, which I have, I think, try to focus on these lifestyle things while I'm treating cancer or seeing someone for a blood problem is just making sure like from A to Z they're, hit trying to focus on lifestyle things. So I think the first thing is like sleep, right? Like I think there's a lot of studies on that most people can't, it's just it causes inflammation and stress in the body over time. So do you think
Mhm.
7 to 8 hours of sleep is going to be something that you're just remembering yourself to just tell every patient that they really, really need that? Like I saw someone today, she sleeps 5 hours and she's got multiple medical problems. And I told her, I think you really need to focus on trying to get that 7, 8 hours of continuous sleep.
I agree. A good amount of sleep replenishes and provides a good cortisol level because the diurnal rhythm is also affects testosterone, and that is a big piece of the puzzle.
Got it. So everything's connected. So, when you get your lab values, what you're trying to say is, maybe, getting, having enough, if you're not anemic or not having enough iron or testosterone, just checking everything together and trying to, it's not that one thing is causing fatigue. It may be a combination of things. Is that what you're saying?
That's correct.
In terms of men's health, like, do you ever, one thing, the most common cancer in men, as you know, and we share patients together with prostate cancer. And so, are you recommending, and there's been conflicting evidence on that, whether to check a PSA or not, but it starts with you really, when someone comes to see you, are you checking a PSA on everyone? And when do you start doing that? And are you checking it every year?
I am checking it every year. I'm also look at the family history. If there is an early onset of prostate cancer in a family member, like dad, grandpa, 45 years or younger. So you're trying to reach out to check them at an earlier age. And of course, if they have symptoms of prostatitis, which is frequency, you will check the PSA earlier. Um, e- One of the things with testosterone replacement is you don't want to feed testosterone and create prostate cancer. So, in if a PSA is elevated, I will kind of almost peel back first and make sure I do my homework that testosterone replacement is appropriate for this patient.
Yeah, I mean, I think that's a good point. Even though testosterone's really good for us, we also understand now that, testosterone feeds prostate cancer. Doesn't mean if you take testosterone, you're going to get prostate cancer. But if someone has prostate cancer, it could potentially supercharge it.
Right.
So I think, that's a important distinction to make. But I don't know what the future holds in terms of the guidelines for taking testosterone. I think it's changing because I never heard about it this much before. Unfortunately, we obviously know that pro athletes have been caught taking it and things of that nature. But it is good for us. Obviously they take it because they want to improve their performance. But for us, it's just for normal people, which is I'm assuming that no professional athletes will ever listen to the pod. But for normal people, we just need it, right? So I think that's something that can be checked if you're fatigued and maybe you don't know necessarily why, and you're getting your sleep and you're eating properly and you're fatigued and you're getting older. Maybe that's something to check and see to keep you going in terms of your fatigue. So is there an age where you'd say you'd stop checking the PSA, or you know are you basing that on the person, or how are you doing it?
Um, the recommendations and guidelines are pushing to line it line it up to stop testing around 80. But again, you have these patients, Neil. They're 80. They only have one comorbidity, and they're probably shooting 72 and smoking you in the golf
Oh,
course.
I don't know about that, but yeah, maybe
I
you're
don't know.
right. Their short game is better.
Well, 150, 150, 150 is in a two putt is par. Last time I checked.
That's right. You're exactly right. Yeah, no, I have patients that have a better handicap than me, which is at 80. You're right. That's just amazing. So I think what you're saying is that if someone's healthy and they're feeling good, you would check their PSA no matter what their age is. Is that right?
Correct. Because I mean, you want to give them the benefit. I mean, if they're in dialysis, they got 10 liters of oxygen at 79. What are you trying to accomplish?
Yeah, I mean, I think you bring up a good point, and it's another thing is, you're the gatekeeper. A patient comes to you, and you know maybe they have all these specialists like me, but like, at the end of the day, they've established that relationship with you. They've known you for a long time, and you kind of have to look at all the medical problems that they have, and maybe doing sometimes. I think testing too much may not be good if someone has such serious problems that they might not live for 6 or 12 months. I
Right.
guess, so I think testing for everything is not always maybe the best, thing. So, speaking of the golf swing, we got to make sure that I think it's a great game to be outside. And I've been reading, that there's something to be said about, nature in terms of the mental health. And we talked about, meditation and things like that. But I think there's even something to be said about being outside in nature. It sounds really hokey, but um, I've seen some research on that. Do you recommend patients, like, sometimes I feel like for the mental health, is there anything else besides like prayer, meditation, yoga, maybe, like, that you're recommending for patients for their mental health?
I think there's free exercises for my geriatric patients. Tai Chi is good, easy movement, breathing exercises, and for golf is great. I think as you get older, problem solving like Sudoku and crossword puzzle, golf is a crossword puzzle. You throw it out, you're out in the fairway, you're in a rough. How do you solve to get back in the green? And how do you not four putt?
Yeah, exactly. I mean, I think thinking about all these things are, really, really important. I know, you're really creative, as, I there's a skill that you have that I think I'll never have, which is, you're able to play an instrument and you're in a band, which is pretty amazing as a physician to a find the time for that, and b be so actually good at it. Because I've heard your band so many times, and I feel like just having a creative outlet, like doing something, whether it's doing crossword puzzles or golf or playing an instrument. I think the more we sit around, I think the more we get closer to dying. That's my opinion. I don't know if you're seeing that now. Besides the guidelines and all that, I mean, you just have seen so many patients over the last 20, 25 years that you've been doing this. Um,
Yes.
is there something where you're just like, look, man, how many, I want you out doing something for 3, 4 hours a day. Is that something you discuss with people, or, and socially, obviously COVID put us way behind. I think we learned from COVID that being alone, not doing things, being at home all the time is just not good for your mental or physical health, the stress you have from all that. So I'm just curious, since COVID, have you made any new changes in your practice to say you have such a high volume of people that you take care of to say, hey, you know what? You need to go to the Bears game. You need to go, do all these sorts of things.
So I'm hoping with the Bears schedule allowing them to have a better, we should combat depression amongst the Bears fans, and w- walking and entering Soldier Field. Hopefully will be a peaceful and mind changing experience.
We'll find out. We'll find out. I mean, we'll just have to see how they play. They certainly improved many of their players, and but we just have our system in place in Detroit. We have that grit. So it's going to be a fun matchup this year. I think any team in the division can win. The good thing about Bears and Lions is that there's one team that we joke around, but there's one team that we both hate more. And I think that's the Packers. Would you agree with that, or?
Green Bay sucks. Green Bay sucks.
So it's actually the people there are wonderful. I got to tell you, I've been to Lambeau once. It was the
Yeah.
best experience. Even when we're cheering for the Lions, they were so nice. It was hard to gloat. It was difficult to gloat. Have you been to Lambeau yet, or?
No, that is one of my bucket lists, Neil. I would love to go to Lambeau.
You've been to Europe, you've been to Portugal, but you haven't been to Lambeau Field, man?
I have to get that done, brother. Next summer, you and I are going.
I don't want to watch the Bears and Packers unless there's a way both of them could lose. And I don't know, but I think it's going to be a tough division. I think all
Yeah,
four teams have players. Obviously, JJ McCarthy on the Vikings will be the wild card.
right.
But gosh, I'd love if you know any professional athletes to have them on the podcast. I'd love to talk to them. But I don't know any. I'm not famous, so. But moving forward, I guess in terms of we talked about testosterone. We've talked in prior podcasts about getting like your general blood work. Is there any other things that that you've changed in your practice, like over the last, let's say, since COVID, that you're recommending for men and women, any patients that you see to do that you weren't doing before? Like, what has changed? I'd say, if you read my shirt, which this video should be up on YouTube soon. What has changed that you would say, you know what, I wasn't doing this before, but now I've been doing this 25 years. What are some other things that you would say, you know what, I'm recommending this now when I wasn't doing it before?
So I think from COVID, I have been placing a lot more emphasis on patients owning their health by getting more. For example, if their family history is riddled with diabetes or heart disease, is getting a coronary calcium score CAT scan. It's about $45. It's way cheaper than a Detroit Lions ticket, or even a Cubs game. And then at least you know about your heart, and you can know your risk factor. So just like golf, I got mine. I had a big fat zero, and I hear that if you score um, a -1, you typically win in golf.
That's right. That's right. So
Yeah.
you scored a zero. I'm glad you brought that point up because I also had a
Yes.
cardiac calcium score,
Yeah.
and for the reasons that you mentioned, it's cheap and it can tell you. I think there's no 100%. My understanding is that it doesn't pick up soft plaques in the arteries, but
Yes.
there's nothing that's 100%. But even if it's 80, 90%, I like those odds, as you said. And
Right.
life is a risk of odds. The games we play are a risk of odds. Whether it's golf or anything else. So you have a zero, is there something where, because we never had these tools 25 years ago, right? You can
Right.
pay $50, you can get a coronary calcium score anywhere. And you know what? Unfortunately, I go on a golf trip with 8 guys, and like half of them have coronary disease, already in their 40s and 50s. So, what I'm wondering for you is you get a zero, you feel like, all right, everything's good. When do you get the next one? When are you going to, like, for you as a knowledgeable doctor, when would you get the next calcium score? Is it just when you're symptomatic? You're doing them every 5 years? Like, how often are you doing them? And do you recommend it for every patient over 50?
I actually have recommended it way before 50, especially if there's family history. As you well may know from one of your first guests, uh, a friend of mine as well, Dr. Dean Ferreira, a fantastic cardiologist. He is just seeing way too many patients coming with acute coronary syndrome at age 40 or younger or mid 40s. That should not be.
That's right. And what you mean by acute coronary syndrome is heart attacks. People are coming in their 40s with heart attacks. And,
Yes.
so let's say, so since we're getting it before 40 if they have a family history, are you recommending it on like everyone at the age of 50, let's say, for example, or no?
Um, a lot earlier, Neil.
So maybe 40 even if they have risk factors. Is that basically?
That's safe to say.
Okay, so you and I, let's say we both had zeros. Thankfully, hopefully my golf handicap will be that one day. So maybe yours too. And then, let's just say, so we have zero. Like I have high cholesterol and a family history. When should I get mine again? Every 2 years? Every 5 years? What do you think?
So my take on it is obviously if you have no symptoms, then you don't go get a stress test. If you had a positive score for a calcium test, you would get a stress test. So I would right now we don't have the firm guidelines for the calcium scan, but my personal choice would be um, if especially if your cholesterol is getting out of hand, every couple of years would make sense.
Okay. So maybe every couple of years. Yeah, I think that's reasonable. For $50, I mean, let's $50 is still a lot of money, but obviously, you know, I'd hope that, more insurance companies would consider covering tests like this, and the reason I say that is I think, as you and I know, we see patients at the hospital, that expense of being in the hospital is a lot more than the $50. If you can
Oh, by
prevent being
far.
in the hospital, we know that people in hospitals get hospital acquired infections. So, hospital is a good place if you're sick and you need help, certainly. But the more we can keep you out of the hospital, the better. And I think by seeing you and doing all these tests, that's what we're aiming for, right? I mean, because if you have a stress test and it's positive, if you have diabetes or, family history, a lot of my friends, they didn't have any single symptom and they had blockages in their arteries. So are you seeing that more and more that like people are not having symptoms of shortness of breath or chest pain?
Yes, it's more atypical. And again, I mean, what do you eat at a Bears or a Lions game? It's a beef sandwich, Detroit Pete style pizza, which you have not shared with me yet.
Detroit
Uh,
style pizza is the best, just so you know, and I like it better than the big brands here in Chicago, the big thick things with cheese. I mean, we could do a whole episode on that, but Detroit style pizza to me is just phenomenal.
so you realize your calcium score and lipid profile are not going to get better with the Detroit style
Oh,
pizza.
I know, but I think the Chicago style pizza has more cheese. Would you agree with that at least? It's so thick.
My friend, you got that.
All right. Yeah, it's delicious. So I mean, I'm
Yeah.
biased. I have a favorite deep dish and a favorite thin crust. But but I would say none of the pizzas that I eat are any good for you. From a health standpoint.
Right.
And pizza's like my favorite food. So I used to eat Luminati's once a week. Now I've cut it down. Once I moved to Chicago and I realized maybe that wasn't a good idea, I've cut it down to once every couple months. So,
Okay.
yeah. So hopefully that goes well. But yeah, I mean, it's really hard to control our diets because we have an abundance of food, and I think as humans we've kind of evolved, at times where in the past our generations, you know maybe they didn't have that food, so it's encoded in our genes sometimes. And I think,
Right.
I really think that self-control is one thing, but your genes are another thing. And as you said, for heart disease and a lot of other diseases, the family history makes a big difference because you can't outrun or outlive your genes per se sometimes, no matter what you do.
Yeah. So for example, from our knowledge, if you're Southeast Asian male, like from your descent, Neil, the coronaries are a little bit smaller, so the risk of heart attack is higher because you have less collaterals. And then for me, as a Filipino, I do have a lot more family history of diabetes, as you have well know with your friends that are Filipino. Our food is rich in carb
Spam is
and
not.
salt.
It's not. All my good friends, they love they eat that mixed with anything. It's crazy. They love it.
Spam rice egg, baby.
Yeah, that's right. That's right. But there's also healthy foods. You guys,
Right.
there's healthy vegetables and
Yeah.
different things you can eat too. So it's definitely. But we all have our taste buds for things, and I think training our taste buds is always a little difficult. To figure out, can I eat, healthy and maybe cheat once in a while. I think that's better than trying to eat healthy every single day. Just
Correct.
trying to do our best. So how do these drugs work? Like I've never taken it myself, and I've never prescribed it. So maybe you can talk about the drugs and what how do they work exactly to help people not want to eat. Now, I'm assuming, Bears fans are probably a little slimmer than Lions fans because, every time you lose, you get stressed and then you don't eat as much. But I don't know if you could talk about how the drugs work a little bit.
Yes. So the first weight loss medications were mostly amphetamines like phentermine. So basically, it tried to speed things up. Your heart rate got higher, and you felt less hunger. And then they had like the orlistat, which is basically a lot of the food would be quickly go through your intestinal tract, and you are in a bathroom 4 7 times every hour. So and now came the GLP-1, and as far as guidelines go, it has benefits for the heart, and it basically it targets a hormone and reduces the hunger, and your sugar intake becomes less. The craving becomes less.
The craving for
And
sugar becomes less. I see. Or
yes,
just for
but
food.
for food in general. So it's basically you're losing weight because you're not hungry. And in a way, it helps other organs like your heart and your kidney process better. For example, if you're in a grocery store and there's 10 people waiting in line, it's going to be a longer, way. But if you're eating less, your body is like that aisle that says 12 items or less. You have a guy there with a banana and a case of water. It's boom, boom, boom. It's very quickly digested. But if you have a lot of food, it's that person with a cart full of groceries. It'll take them a while to get through you know the the cashier, basically.
Yeah, I mean, it's crazy how we have tools for the right patients to help them and live longer and healthier lives, as our life expectancy has increased over the last 50 years. So, um, you know, I just want to thank you very much for being on the podcast and taking time out of your day. And
Absolutely.
hopefully we can do it again. And I have a gift for you that I'll give you. And thanks for providing this information for everybody.
Absolutely, Neil. I'm more than happy to be here, and I'm blessed to have and be able to talk to you and kind of spread the word about health and about how much better the Bears will be.
Yeah. Oh, so last question. Speaking of disinformation, um, my last question: what is the biggest health myths that you're seeing? Someone comes to your office, and what's the biggest thing that you're seeing that just isn't really true, based on the evidence that we have, or may be true one in a million times, but for the most part is not. Is there something that you're seeing online or that people are coming with that you're having to just explain to them that this is just not really accurate?
So I'm gonna choose to talk about the GLP-1. If you look at the formal study, the weight loss that we were expecting to provide just statistically significant benefits in trials is just 15 pounds. Obviously, I can tell you about patients losing 60 pounds, 80 pounds, 100 pounds. I think down the road, the impact of the tremendous weight loss, I mean, the risk of the benefits versus the actual harm, we will know more down the future. I mean, weight loss of 15 pounds is great, but you're aiming to lose 60 pounds, 80 pounds off. I think down the road, statistically, I don't know if it's going to add up with the clinical trials that it'll be more helpful and not harmful.
Yeah. All right. Well, thanks a lot. We'll see you next time.
All right. Have a good one.